It's really, really nice to be here, and I very much appreciate the HDA sort of inviting me to give a talk to you during HD Awareness Month. I guess it's probably good to explain a little bit about why I'm here and why I'm talking today. I'm a clinical psychologist, and I've been working with people with neurological conditions, including Huntington's disease, for about 10 years, give or take. And I'm also a clinical researcher, so I do research into Huntington's and also other conditions which are associated with similar kinds of difficulties to what we see in HD. So I want to talk about some very basic genetic elements of HD, which in many senses, I don't need to know a huge amount about that because I'm a psychologist rather than a biologist or a geneticist. So I just need to know how HD affects people on the level that I work at, rather than knowing about how the biological or chemical complexities of HD kind of affect people on the molecular level. So I'll just talk to you a bit about the kind of understanding that I need that you probably already have if you're here. So HD is a rare disease which is sort of affecting about 6 in 100,000 people worldwide, although it can vary a little bit depending which continent you're looking at. And it's caused by genetic expansion on a specific gene, which causes the production of a mutant protein which can interfere with cell function, and that causes the kind of symptoms that we see in HD. I guess from my perspective, what's really important is the way that HD can affect whole families. So it's inherited from an affected parent in the vast majority of occasions. And what that means is that you might have families where there are parents and children and other sort of members of the family who are either affected by HD or have been at risk of HD at some point. And then there'll be other people who are associated with the family in one way or another who haven't got HD themselves and were never at risk, but are still very much affected by it because they might be in a caring role or care about somebody who has HD. I'm not going to linger too much on this sort of level of things because I'm much more interested in my work and how Huntington's affects people and families. So moving on to how HD starts to affect people in a physical way. HD is usually diagnosed or is diagnosed when people start to show physical symptoms, so changes in the way that they move, maybe moving a bit more slowly or starting to show the career that I'm sure a lot of people here are going to be familiar with. And the important part about that is that when it starts to kick in, firstly, you're around 30 to 50 or 35 to 45. So you've had a lot of years to become independent and to develop your skills and to work and to live your life. And then you start to have these really significant changes in your ability to do the stuff that you've been able to do for all that time. So you might start to have difficulty with things like with driving and later with walking and things like chewing and swallowing and speaking. And these are sort of really big dramatic changes in the things that you're able to do that you've always taken for granted maybe. And it can really start to affect your independence as a person with Huntington's. But it also changes how people around you relate to you. If you've always been very independent, always taken care of yourself and always managed everything yourself, but then suddenly you're needing some help with some things that you've always thought were things that you could do without thinking about them. And then you need help kind of getting around, maybe doing things around the house. That can really change your relationship with the people around you, and it can give them things to do which they're maybe not used to having to do. And that can be quite a tricky dynamic to navigate around. So although we're very much talking about physical symptoms here, it's actually got big psychological implications as well. So I want to move on from physical symptoms from the cellular level and start talking about the area that's close to my heart, which is the cognitive, the thinking, the behavioral and the emotional difficulties that come with Huntington's. And what's really important about those is that they actually predate those physical changes that are associated with the diagnostic part of HD by up to 15 years. So somebody can start to experience these many, many years before they start to have those visible physical symptoms of Huntington's. And those are really, really important. And obviously the area that I study in. So cognitive changes can include all kinds of difficulties. And I guess the people who are here are likely going to be very familiar with that. Some of the most important ones are changes in memory. So people might start to have difficulties with retaining information, especially if they're trying to remember a lot of information or there's lots of information coming at them at once. They might not be able to remember things that have happened to them as well as they used to. And those things can start to affect you on quite a practical level. So they can start to interfere with how you remember appointments or do things in daily life. And that can be quite sort of practically frustrating for people and quite scary and upsetting as well. You can also find as Huntington's progresses that you might start to have problems with feeling a bit confused, not always knowing where you are and maybe losing track of the time a bit, and that can get worse as time goes on. So again, that's pretty scary. That's quite upsetting. You also start to see changes over time in Huntington's in terms of speed of processing, which is kind of a neuropsychological term, but it's talking about how fast we can process and use information that we hear. So you might find that a person with Huntington starts to respond a bit more slowly if you're speaking to them, or if they're trying to do something that they've done before, maybe they're doing it a bit more slowly than they used to. And that's because maybe it's taking a little bit more time to process that information than it used to. And again, that's something that can progress as the HD goes on. So these are some of the cognitive changes that happen, and they're probably pretty familiar and sort of quite intuitively understandable, I think. But another term that we chuck around a lot as psychologists is executive function, which is not that sort of easily understandable compared to some of the others. But they're also some of the most important changes that we see in HD, especially early on, before those physical changes happen, and some of the things that show earliest because they relate to some of the most complex things that we do as people. So executive function is kind of an umbrella term that it refers to a bunch of different skills which are easily recognizable. So things like, I've put here putting the brakes on, which I like as a way of putting it, but basically we all have moments where we think something or we want to do something and we decide not to for one reason or another. We have these impulsive responses, but we're able to what we call inhibit them. So we don't go ahead and do the thing that's socially inappropriate or risky, because we have a think about it, we have a moment, and we're able to hold that back. Now, somebody with Huntington's, as time goes on, might find it more difficult to put those brakes on or might not be able to do it at all. So you might see that with a person with Huntington's starting to behave in a more inappropriate way, or maybe say things that they might not have said before. So it can almost seem as if somebody's personality is changing a bit, because people might say stuff that actually is quite outspoken or not really like the kind of things they would have said in the past, which can be quite tricky actually, because that can be difficult for relationships for one thing. And also those impulsive behaviors that come with not putting the brakes on in the way that you're used to can mean that people end up putting themselves at risk, maybe doing things that aren't particularly safe, which can be quite troubling for everybody really. I also want to talk a bit about part of executive function, which is to do with switching between tasks. This is something that we're mostly pretty good at. For example, if you're doing something in your house, if you're cooking and somebody knocks on the door, you're able to kind of smoothly change your focus away from what you're doing, you're cooking, whatever it is that you're doing, go and answer the door, have a conversation and deal with that, and then switch back to doing your cooking in the kitchen, for example. So that's all very smooth, and you're able to change from one thing to another and then back again quite fluidly. We sometimes test these things with, you can see on the top right of my screen here, we've got something that's called the Stroop test, which some of you might have come across before. And this is a really nice example of how we can test somebody's ability to switch between rules that they're using. So as you can see, we have the names of colors and they're written in different colors of ink. So what we would ask somebody to do is to read the top line, just to read the words out, which in this case would be blue, green, yellow, brown for the top line. And then you ask the person to switch the rule that they're following. So instead of read the word in front of you, it's read the color of the ink that it's printed in. So in this case would be red, yellow, green, purple. I don't think I've embarrassed myself there, hopefully. But what that's asking you to do is to stop using one rule and to switch to using a different rule, which can be really tricky for anybody if you're tired, if you're stressed, if you're trying to concentrate on other things, if it's noisy around you or there's a lot of distracting stuff going on. And when you've got somebody who has Huntington's, it can actually become a lot trickier to switch from one rule to another in that way. It gets a bit more difficult to disengage from the thing that you're focusing on and move to something else. Now that's a clinical test, and we know that clinical tests are a bit of an indicator of things that you might be finding difficult in day-to-day life, but some of the ways that it would actually affect you in day-to-day life is maybe finding it difficult to do those things like disengage from the job in front of you and switch to doing something else. And that's when you can start to see those kind of repetitive behaviors that we sometimes see in Huntington's, where it's difficult to stop focusing on something and to think about something else. It might get very stuck on a kind of routine or something that feels very important and quite hard to disengage from. And again, that can put a lot of pressure on the person with Huntington's and on the people who are trying to support them. Another thing that is quite difficult in HD at times is the changes in memory and ability to multitask. So we know that people start to find it a little bit more difficult to manage lots of information or to manage different rules and hang on to information and manipulating it in your head. So again, one of the things that we might use as a therapist is to say to somebody, can you take 7 away from 100? And typically it's not too difficult for people to say, 93. And then you say to somebody, can you take away 7 from your last answer? So then that gets a bit more tricky, because you have to hold your last answer in your head, which is 93. You have to remember that you have to take away 7. You have to figure out the correct answer, and then you have to give that back. And although that maybe doesn't seem like a lot of things for a lot of people who are here, for people with Huntington's, as time goes on and as they get a little bit further on in the course of Huntington's, it can become really, really tricky to do all of those things at once. So you might find that people give the wrong answer, or maybe they can't hold on to the question and the information that they need, so they might struggle to answer at all. So it can be really, really tricky. And of course, these problems with working memory and multitasking also show in day-to-day life, because we all have to multitask and we all have to kind of hold information in our heads. And if that gets trickier, it can make day-to-day life a lot harder too, which can be, again, really frustrating and really upsetting. There are a lot of different aspects to executive function, but the last one that I'm going to talk about here is around what we call loss of insight. So changes in how well somebody can understand the difficulties or the symptoms that they're experiencing. So it's not all that uncommon in my clinical experience for people with Huntington's to struggle a little bit with understanding how much they're struggling, or the ways in which they're struggling. So sometimes people can think they're able to safely walk when maybe they're not able to do that anymore, for example, or that they can safely drive when it wouldn't really be safe for them to do that. So it can lead to some real difficulties for the safety of the person who has Huntington's, because they're trying to do things that they maybe don't understand aren't so safe for them anymore. And it can also be tricky for family who are trying to support those people and keep them safe, because it's really difficult to say to somebody, I'm not going to give you the car keys because I don't feel like it's safe for you, if that person doesn't feel that there's anything that would stop them from driving safely. So it can lead to sort of confrontation, aggression, frustration, distress. It can be really, really hard on the person with Huntington's who doesn't understand why things have to change, or why it seems that things have to change to their family. And it's really hard on family, because who wants to do that to their loved one and to see them being upset? It's really, really tricky. And from a healthcare professional point of view, it's hard for us to make sure that we're offering the right support to people if we don't know what's going on. Excuse me. So when a person with HD comes to see us, and if they tell us that they're okay, that they're not experiencing sort of emotional or thinking difficulties, and we don't have any other way of knowing, then we can only work with what we can see and what we're told, which can be really, really difficult. So how do we try to address that? So we know that people with HD have a huge range of symptoms which have been associated with mental health or poorer mental well-being. So it can be things like anxiety and low mood, irritability, disorientation, as I've said before, so confusion, behaviors that can look a little bit obsessive compulsive or repetitive. And they're not always able to tell us about that terribly well because of a whole host of reasons. So as I said, there might be physical changes in how well somebody's able to do things, which might include speaking. There can be cognitive changes around how well somebody can remember, for example. So a lot of our clinical tests say, how have you felt over the last 2 weeks? And speaking for myself, sometimes it's pretty hard for me to remember how I felt 2 weeks ago. So if you're having memory difficulties, if you're somebody with HD and it's progressing, then maybe it's going to be really difficult for you to remember how you felt 2 weeks ago. So how can you then communicate it to your therapist or your doctor if they're asking you how you were feeling a fortnight ago? And there are also difficulties with insight, as I said. So perhaps you're not as aware as you used to be of the kind of difficulties that you are experiencing, in which case, again, you can't tell your therapist, you can't tell your doctor. And importantly, we don't always talk about this as much as I guess I think we should, but personality plays a role as well. There are some people who just don't like to talk about how they're feeling, and they're not going to start now. So sometimes you say to somebody, how are you feeling? And they just say, fine, because they really don't want to talk about it. And why should we expect that having Huntington's would change that? Some people are just not particularly keen on talking about how they're feeling. So there are loads and loads of reasons why people with Huntington's might not be able to talk as well or as much as they used to about how they're feeling and how their mental health is feeling at the moment. And so we know that on average, people who have Huntington's tend to report that they have fewer symptoms relating to their mental well-being than their carers do if you ask them about the person with HD. And the person with HD also tends to overestimate their abilities. So they think that they can do more than they can, and they think that they're having fewer difficulties than they are. And all of this presents a big problem for working with people with Huntington's, keeping them safe and making sure that their well-being is as good as it possibly can be. So I'm hoping that I've laid out the problem fairly well so far that we're trying to solve. My colleagues and I then went ahead to do a study to try and find out what helps with this. What effect does it have, for example, if you bring somebody who knows you really well along to your appointment when you're talking about your psychological well-being? So we've used the word informant throughout here, which is the word that we use for somebody that knows you really, really well. So your carer, your spouse, another family member, somebody who knows the person with Huntington's really well and can talk about how they're feeling as much as anybody ever can when you're talking about somebody else. We used data from the Enroll HD trial, which I think probably a lot of people here will already be familiar with, but it's a huge international study which sort of observes symptoms and Huntington's progression across a huge group of people worldwide, looking at not only people who have HD themselves, but their family members, so people who were either at risk or people who have joined the family in some way that meant that they weren't at risk, which might include marrying into the family, for example. In our case, we used data from about 8,000 people. So people who either had Huntington's after they started to have the physical symptoms that I talked about earlier, or people who had not had any physical symptoms yet, but they did have the HD gene expansion. So they knew that at some point they would develop HD. We also looked at people who come from a family with HD and who could have inherited the expansion but had tested negative. So that might include somebody who had a parent with HD but didn't actually inherit the expansion, but maybe a sibling did. And we looked at people who'd entered a family with HD but weren't at risk. So for example, as I said, spouses or maybe people who were adopted into the family. So they were never at any risk of inheriting the gene expansion, but really importantly, they've still been exposed to a lot of the stresses that come with living in a family where there is HD. And what we were looking for really was to find out whether having somebody that knows you really well, somebody that hopefully understands you and how you're feeling as much as anybody can who's not you, whether having them in the room with you when you speak to your healthcare professional makes a difference to the kind of mental well-being difficulties that are being reported. And we were kind of expecting that when a person who has Huntington's, especially after they've started to have those physical symptoms, which mark that you've kind of moved on a bit in the course, we thought that those people who had their carer present or the person who cared about them would have higher scores on the measures of mental health symptoms compared to people who had HD but came to the appointment on their own. And to some extent, we did find that. So we looked at apathy, for example, so a sense of being demotivated and maybe being a bit less emotionally responsive than they used to be. And we found that when you brought a carer or another informant with you, your scores for apathy tended to be higher. So people were reporting worse apathy when they had somebody there with them than they did on their own, which kind of makes sense, right? Because even if you are somebody who is maybe losing your insight a little bit and you're not remembering quite as well, so maybe you're not making the best judgments of how you've been feeling over the last couple of weeks or however long, but maybe you have your partner with you or somebody who knows you really well and can sort of say to the healthcare professional, well, okay, so you're saying this, but actually I have noticed that you're a little bit less interested in the things that you used to care about. You're not going out as often as you used to. You just seem a little bit less responsive. That's really important information that can be given to the healthcare professional and can affect the ratings that are recorded in terms of symptoms. And maybe that means that we're just getting a bit more of an accurate understanding of the kind of difficulties that person with HD is experiencing at that time. So as I say, this was kind of in line with what we were expecting. Things got a little bit more complicated when we had a look at mood difficulties. So things like low mood, anxiety, thoughts about self-harm and suicide, which are obviously incredibly difficult for people. And what we found in this case was that having that sort of close other present with you didn't make any difference to the ratings for the people with HD or actually any of the groups that we were looking at. So we weren't getting that same effect where having somebody who knows you really well could increase the ratings or provide potentially more accurate information, which is weird because we weren't expecting that. The theory that we have around this is that unlike apathy, low mood and anxiety are not as externally visible. So for somebody who is less interested in what they used to enjoy and less motivated with higher ratings of apathy. You can look at somebody and you can see that, especially if you know them well. So you're going to be able to tell the difference between how they're acting now and how they used to act. But when we come to talk about mood, we're actually talking about a much more of an internal phenomenon. So it's kind of difficult to know if somebody is experiencing low mood or anxious thoughts if they don't tell you. It's a bit different. So maybe it's harder in this case for somebody who knows the person well to come and kind of correct those estimates up when they're talking to a healthcare professional. So that was our theory anyway. We have yet to test this, but that's the kind of hypothesis that we're working on at the moment. What's really important is this presents a risk that we might be underestimating as healthcare professionals, the kind of mood difficulties that people with HD are experiencing. And if that is the case, then that means that we're not supporting people as well as we should be or could be, and we're not able to improve people's well-being as much as we would want to. This was this was an interesting finding as well. This is the third of three. We looked at people's ratings of irritability as well. And what we found was similar to apathy and similar to what we'd expected. People reported higher irritability scores when they had somebody who knew them well with them than they did when they came on their own, which again is in line with the idea that perhaps people with Huntington's are less able to remember or have less insight into how their mood has been over the last little while, and they get a bit of help from the person who comes with them. That's fine. What we also found was that people who didn't have HD, so were from those other groups who had either tested negative or had never been at risk of HD, those people also reported higher irritability scores when they had somebody who knew them well with them, which kind of says that everybody is underrating their own irritability a little bit, which almost made sense when we thought about it, actually, because when we think about the word irritability, it's not a very socially desirable trait. I mean, nobody likes to think of themselves as irritable, do they? It's kind of, yeah, it's a bit like grumpy. It's not the kind of word that you want to associate with yourself. And when we get annoyed, when we get upset, we think about ourselves as being annoyed or upset or angry or frustrated. But we don't think of ourselves as irritable because of that kind of association of it being not a very nice thing to be. So it seems that across the board, people tended to underrate their irritability, whether or not they had Huntington's. Although from an HD perspective, this importantly flagged up that, again, if a person comes for an assessment by themselves, that person with HD is likely to give a less severe picture of the irritability-related symptoms they're experiencing compared to if they bring somebody with them. So I guess one of the really important takeaways from that is that we're really relying on people that know the person with HD well to make sure that we're getting an accurate picture of the person with HD's well-being. And it's really important to have both of those people there, the person who has HD and also the person who knows them really well and can help provide that information to kind of correct it up. We know this is really important. And maybe when somebody doesn't have someone who come with them and to help correct it up, it's a bit of a concern, isn't it? Because we don't know if those people are getting the right support or if they need to be understood as fully as they could be. So this is something that we really need to work on, I think. So we know that mental health symptoms in HD are really important. We know that there are a lot of difficulties that people can have when they have HD, but we don't exactly know where they're coming from. So physical symptoms, for example, are really clearly linked to HD progression. They happen at a certain point in the course of HD, and we can kind of predict more or less when that's going to be. And we know which cognitive symptoms, so thinking skills, are affected and when in the course. And it's not the same time for everybody, but there is a kind of broad outline that people more or less follow. And this is also the case for sort of functional abilities. So things like being able to cook and clean and look after yourself and to manage finances and things like that. We see changes in those things in a broadly, very broadly predictable way. We don't see that for mental health symptoms. So for poor mental well-being, that's kind of occurring at different times in the course of HD, which led us to kind of think, what else is contributing to these difficulties? Because it doesn't seem like it's just arising from HD progressing in the same way as, for example, the physical symptoms might do. We actually thought that perhaps some of this is coming from living in a very stressful context. So as I'm certain everybody here will be aware, HD puts a huge amount of stress on the person who has the Huntington's condition, but also the people who support them and the wider family for lots and lots of reasons, which I'll come to in a minute. So we thought, can we have a look at families who are affected by HD, not just the people who carry the gene expansion, but everybody who's kind of in that family unit? And can we see what kind of difficulties in terms of well-being we're seeing across those groups? So there are a lot of reasons why HD can impact really quite severely on families. And it can be things like the change in personal narratives and expectations from life. So we know, for example, that people kind of have expectations about what their life might look like. If you're somebody that was aware there was Huntington's in your family, then that can be a really dramatic revelation and very painful and very difficult. And in a different way, growing up and knowing there is HD in your family and gradually coming to terms with that can be incredibly difficult too, because all of those things kind of impact on what you expect and the plans that you make for the future in a way that a lot of medical conditions actually don't, because it's incredibly hard to have this knowledge that you have the gene expansion and that it's going to affect you in coming years, and you kind of have to plan for that and think about how you're going to build that into your life. It's tricky and it's painful. There's also the difficulties around in HD affected families, you're likely to have relatives who are either affected by HD, or possibly you might have lost people who had HD, and that's really, really tough. And you might be worried about other relatives, so people in the family who are at risk, for example, or people who have been diagnosed as having the HD expansion but aren't yet affected by it. So you have this kind of anticipatory worry about what's going to happen to them and how it's going to go for them. And on top of all these emotional difficulties, you have financial difficulties as well, potentially, because HD can mean changes in job roles and the number of hours that people can work, and changes in who works depending on kind of jobs that people do. And that can be really tricky. So on top of all of the emotional difficulties, there are financial stresses. There can be house moves that need to happen, for example, or changes in how childcare is managed. And life can get really, really complicated, as I'm sure everybody who's listening to me is already well aware. So the important thing about all of these things is that while people with HD are really, really affected by that, of course, actually, a lot of these things that I've just described that are on this slide are also going to affect people in the family that has people with HD. It's also going to affect their relatives and the people who care about them, because they're also experiencing loss and worry and changes to their expectations about the future and changes to finances. And that can be really, really tough. I should say, by the way, that our references in this presentation, they're sort of down there at the bottom. I wanted to keep this quite reference light. I mean, they're interesting to have there, and they are kind of on the end of the presentation. I'm happy for the HDA to share them with you, but I don't want to go particularly academic with this. So people are very, very welcome to email with questions or to follow up references later, but I'm not going to talk too much about them as I go. They're just there for people who are interested in following them up, really. So we went on to do another study looking at mental well-being across families affected by Huntington's. In this case, going back to the Enroll database again and looking at about 5,000 people, again, looking at those same groups, people who have HD either after the onset of physical symptoms or before those physical symptoms have started, but knowing that they have the gene expansion. And we also looked at people who come from a family with HD and could have inherited the expansion. They were at risk, but they've tested negative. And we looked at people who came from a family with HD, but they were never at risk themselves. So that's the partners, anybody who's adopted into the family, people who were never at risk, but have still shared that environment and those stresses that we were talking about on the last slide. And what we did was look at the symptoms of poor mental well-being that we know are associated with HD. There are plenty of papers showing that people with HD can experience these symptoms, but they can also be stress-related. And that includes things like low mood and anxious thoughts and being quite irritable. We know that these things are commonly associated with HD, but we also know that somebody who is stressed, who is tired, who is worried, can start to show some of these difficulties and these sort of elements of poor well-being. So we wanted to see how much is specifically associated with having the HD expansion, and how much of it is maybe part of just living in this very stressful context with all these things that you need to worry about. And what we found was actually surprisingly consistent. There were significant factors that were affecting people across all those groups, so people with HD and people who don't have the HD gene expansion. We found these four sets of symptoms, I guess, might be the way to talk about it. And the first one was anxiety. And I think the thing about all four of these, they're actually really understandable. You can see where they're coming from. So everybody in these HD affected families, not everybody exactly, but this was typical of the groups that we looked at. There are always exceptions. But people reported feelings of dread and worry about the future and panic about things that are going on now and struggling to relax. And given the difficulties that people can be dealing with in these families, that's actually pretty relatable, isn't it? And the same goes for low mood. So people talked about not being able to enjoy life, not feeling things are fun, not feeling able to look forward to the future. We also found that people talked about irritability, which is absolutely a sign of stress, isn't it? So things like losing your temper or showing outward signs of anger, like slamming doors or throwing things. You know, people talked about signs of being irritable and angry. And we also talked about, it's called self-harm on this slide, and that is what we called it, but at the same time, it's also described by others as inward directed irritability. So frustration and anger and thoughts about harming yourself, a disappointment in yourself, those kind of very negative, very aggressive towards yourself kind of thoughts. But the really important thing to flag up here is that these difficulties were not just for people who had Huntington's, not just for people who were kind of past that stage where you get that physical onset of symptoms. This was everybody in HD affected families that was reporting these kind of difficulties. So this is always a really important question, I think, for research. Why does it matter? Partly it matters because this is helping us to understand the well-being of people who have HD. We're starting to understand a bit more about where some of these difficulties with well-being are coming from, and that actually a lot of these difficulties are shared with other people in HD affected families. And that could be really important because what recent research is showing is that right now our therapeutic interventions for people with HD are not doing as well as we would want them to, or as well as we would hope that they would. And we want to try and improve that. So current research is looking at where are we missing the mark and why are we missing the mark and what can we change to make this better? And actually what some of this research is showing is that maybe some of the difficulties that we're seeing and maybe some of the reasons that we're not able to support people by giving them individual therapy is that actually we're looking at a whole affected family system where everybody is struggling and everybody is experiencing these stresses. So realistically, if you take the person with HD and you have individual therapy with them, but then they return to that family system where all of their stresses are still there and everybody else in that system is still really struggling, it's going to be difficult for that person to maintain good psychological well-being or put into practice the skills that they've learned in therapy in the most effective way. So these things are really important. And it also highlights that families sort of have psychological needs too. Supporting the person with HD is so important, but it looks like supporting the people around them is also going to be really helpful for them and really, really helpful for the people who support them. It's also important to think about, in a way, this is kind of, it's validating some of the difficulties that people in HD affected families are experiencing with psychological well-being, and it's making them understandable to practitioners who don't specialize in HD. And that can be really, really important because one of the things that we hear from people who are not in specialist HD teams is that they don't quite know how to support somebody with HD in the best way. And that can make them quite nervous and quite worried about engaging with it. So some parts of the country don't have specialist HD teams, or if they do, they're a very long way away and the accessibility is really not brilliant. And that means that a lot of the time you get older adults teams locally or mental health teams trying to support somebody with HD when they just don't have that kind of confidence to support somebody with what they see as a specialist in complex condition, which of course in many ways it is. But actually these things that we're talking about, low mood, anxious thoughts, feeling irritable, feeling angry with yourself, those are psychological difficulties which are understandable to these healthcare teams, even if you're not an HD specialist, and they're things that you can support people with and you can try to treat. So that can only be a good thing to help people feel a bit more confident about engaging with it and providing support to people with HD and their families. And I just wanted to talk a bit about ways to look after your well-being as we're wrapping up, really. I think the first thing, whether you're a person who has Huntington's or somebody who supports someone with Huntington's, is to look after yourself. And it does sound selfish and it's really difficult for people, I think, to take time to look after themselves because we worry about other people, don't we? It's kind of what we do. But there's an analogy that we like to use in therapy that is about putting on your own oxygen mask first. And what that means is it's talking about the safety spiel you get on the plane before you take off, where they talk about if the worst happens and the oxygen masks drop from the ceiling, it always says, don't help somebody else, put on your own mask first. And the reason that they say that is because you can't help anybody else if you're not able to breathe yourself. So the best thing you can do to support everybody around you and to take care of yourself is to look after yourself first and make sure that you can breathe. And it's the exact same thing in terms of looking after your emotional well-being. You cannot pour from an empty jug. I'm mixing my metaphors, but you can't help anybody else if you're not in a state to give and to look after them. So it is really important to try to look after yourself as well as you can, even when it's really tricky and really challenging, which it really can be, can't it? So some of the simple things you can do is to try and make time for things you enjoy, even if it's tiny amounts of time, tiny things you enjoy, even little things that give you a boost, like going out in the garden for 5 minutes. Just little things can make a difference. Looking after yourself physically is really important. So getting enough sleep, drinking water, eating healthy foods, maybe avoiding alcohol and caffeine if you find those things affect you negatively. Some people find them helpful. It's very much what works for you. It's worth looking into relaxation strategies just to give yourself a little routine that sort of helps to keep your mood a little bit up, help to bring your anxiety a little bit down. YouTube is full of brilliant stuff. So you can find, for example, very physically based relaxation exercises, which work on relaxing your muscles and helping you experience a sense of bodily relaxation. So progressive muscle relaxation is generally the kind of thing that we would recommend for that. And you can also find visualization exercises, which get you to take a walk on the beach in a guided meditation, or try and imagine things like your thoughts floating away down a stream on leaves. And these things, they kind of sound silly if you've never done them before. I thought they sounded silly before I started doing them, but I find them really helpful for me. I recommend them to the people that I work with therapeutically. They do tend to work, so I would hugely recommend giving them a try, even if they seem silly, and just see what they do for you. It's also really important to be guided by your values in trying to look after your well-being. I think that one of the things about HD is how much it can change what daily life looks like, and the things that we want to do and the things we aspire to, which can be really, really tough, and it's a big loss, and it's really important to acknowledge that and to adjust to it. But what we recommend, and what I try to do with my clients in therapy, is to think about what it is about the things that you want to do that makes them really valuable to you. And people often say things like they want to climb a mountain, or they want to go traveling in far-flung places, and now they can't do that, they say. And a lot of the time it's true, either because they're a person with HD or another neurological condition, or they are supporting somebody who has something like that. And that makes it really difficult for them to do those things that they value. And it's really important to accept how painful that is, of course, but at some point, we usually start exploring what it is about those things that was so important and what made life feel worth living when they were doing those things. And a lot of the time, it's something about being adventurous or doing new things or feeling physically exerted, climbing a mountain, that kind of thing. So often, once you start digging into it, there are ways that you can still try to meet those needs in the changed context that you're living in at that time. And it's about exploring with that person. I'm not going to give examples because it's so different for everybody, but there are often ways that you can try to get enjoyment out of life by trying to follow the things that matter to you, and it will lead you to the right place to just try and have positive and meaningful experiences. And it's also really important, if these things are not working and they're not keeping you afloat, then go and seek support from your GP, from the HDA specialist advisors who are really good. If you're connected to an NHS HD service, then speaking to them can be really, really helpful to find out about support groups locally and other services that might be helpful. Just talk to someone, don't try to cope alone, and do it early if you can. I think we often have a tendency to try and keep going even when things feel really, really tough, because we think it's all right, I'll just push through, I'm here for somebody else, I'm just going to keep going. Maybe even thoughts about other people deserve help more than me, you know, I'm struggling, but I'm okay just now. And we keep going until it's too hard, and then we fall apart. And it's much, much better to look for help when you're just starting to feel that strain and things are starting to feel tough and it feels like you can't manage, because that's the point at which you can sort of, I don't know, get the best help quickly and help yourself stay on that level instead of things getting tougher and tougher until it's too tough. I just want to finish off by thanking the HDA very, very much for inviting me to speak today. It's been lovely to have the opportunity to talk about some of the work we're doing and why it's important to me, and hopefully I've made it clear why it matters. I certainly think it does. I would like to thank Enroll HD and the thousands of people who've participated in their research and made everything I've spoken about today possible. I wanted to name check my co-authors, without whom I would not be here, and I wouldn't have anything worth saying if I didn't, or if I did. And I would like to thank all of you very much for listening to me. Thank you.